Hi, I'm Anne-Marie Navarre, Cardiology Fellow at the Duke Clinical Research Institute, and I'm pleased to be here with Dr. Paul Whelton. He's the chair of the SPRINT trial, and at AHA Scientific Sessions 2015 has just shown us that a blood pressure reduction to 120 compared with prior goals of 140 has led to a 25% reduction in the composite endpoint of cardiovascular events and death, and a 27% reduction in all-cause mortality. I want to thank Dr. Whelton for being here and start with a first question, which is, are you surprised at the findings of the study?
Well, great to be here, Anne-Marie, and I'm delighted. And it was a bit of a surprise because we were sailing along happily until one day I got a phone call saying the Institute has decided to stop the blood pressure intervention due to benefit. So that's a lovely surprise to get.
So really compelling findings, not just in terms of heart failure, new heart failure hospitalizations and heart failure events, but also a reduction in all-cause mortality. How do you think providers should implement the results of your findings? Or should we wait until the guideline committee has a chance to take a stab?
Well, we were really pleased. We got a good blood pressure separation, and we were really pleased when you put that combination of the primary composite and all-cause mortality together. I think it is very powerful. Now you have to weigh that positive side of the ledger by saying, what are the possibility for adverse events? We did see some signals. I don't know what they mean. They're mostly around renal disease. We saw some signals around hypertension, syncope, but didn't result in injurious falls. So our interpretation is we don't know for sure what the potential for adverse events will be in the long term, but very powerful results in the short term. Now, then you have to say, to whom do we generalize these results? And straight off, you can say people who look like those who were in the trial. It's about 20 million people, we think. And then you go further. We excluded diabetics, we excluded stroke victims, we excluded polycystics because there were trials in those other areas. And what do we do with them now? And, we'll all come to personal opinions. The guidelines committee will wrestle with this. So that's a bigger, I think the question itself within the trial cohort is settled. I would like to think so, at least. I think the next question is a challenging one. It's challenging always for trials. We can't do trials in everyone. And we can say there are some to whom you may be very confident about generalizing the study. To others, very confident that you can't generalize the study. And there are a lot of people in between.
So speaking of those in-between people, what do we do with diabetics now?
Well, we do have a bit of a conundrum. ACCORD, which tested a very similar question in diabetics, didn't see a positive outcome. And it really is consistent with SPRINT, that is to say, it lacked a lot of statistical power. So lurking within those results could have been a benefit as much as we saw in SPRINT. And we were lucky. SPRINT had more than double the sample size of ACCORD. We had a high risk, and our expected risk was just about what we experienced. So we had more statistical power to answer the question. And there are some other differences between ACCORD and SPRINT as well. So it's not a perfect answer. I think some clinicians are going to say, I'm going to wait. But even if we were to start a trial, a large trial with a lot of power in diabetics, we wouldn't get an answer for 5 to 10 years at the earliest, in my opinion. So a lot of clinicians are going to have to make their decision now. And I think some are going to say, every trial that has shown benefit with any hypertensive therapy has shown equal benefit in diabetics and non-diabetics. So why would SPRINT be any different? So it is an imperfect, and like many things in the practice of medicine, we have to get the best science, then try to figure out how to use it, sit down with our patients and have a good discussion.
So, for those of us researchers in the field of hypertension, given the findings of SPRINT and also the needs of the guideline committee, what do you think are the next really big important areas of discovery for hypertension control?
Well, I mean, there are lots of important areas. And of course, the way we treat hypertension right now is the way we treat lots of things. It is, if you will, a group treatment. Because we say there are 330 some hypertensives for every one that gets kidney disease. What's going on? I mean, could we do better in our understanding of risk? And maybe it is imaging that helps us with that. Maybe it's genetics that helps us with that. But right now, our treatment is fairly general. And we would love to have, if you will, individual specific. You can put any term you want on it. Whether we can get to that in the short term or not, I don't know. But there are obviously lots of other questions that apply as well.
Final question. Knowing what you know now, would you have done anything differently when you designed SPRINT at the get-go?
I don't think so. Of course, it would be lovely in a way to have diabetics in there. I think that's an important question for the community. The stroke question has been partially answered, at least, by SBS3, which didn't quite definitively and convincingly demonstrate benefit, but it came very close to it. The trends were definitely in the right direction. So we'll have to wait and see, but I think that's the one area where it would be nice, and perhaps a trial will be done there. It's certainly ethical to do it, and whether it's in the US or in China or somewhere else, I hope there will be a trial done in that area. The other thing in SPRINT is we've answered the cardiovascular question, but there are other questions that we would like to be able to contribute to. One is an important one on cognitive impairment and dementia and MRI changes in the brain, and that's something we're actively looking at. We've finished the cardiovascular part, but we are bringing our participants back in for final visits, check their renal function, and look into that cognitive impairment, dementia question. So there'll be obviously more coming out of SPRINT. We'll be listening to the community to understand what are the highest priority questions that are on people's minds that we can answer from SPRINT.
Well, exciting news from SPRINT, from the American Heart Association Scientific Sessions in 2015. As we just heard, a lot of new and exciting results to come. Keep following this at the Duke Fellows blog. Thank you.